This Collaborate is focusing on pediatric abusive head trauma, and you will find your PowerPoint to follow along with the information. In 2010, the Kentucky legislative session, and the exact number of that session was 314.073, identified that there should be nursing continuing competency requirements for a pediatric abusive head trauma, formerly known as shaken baby syndrome. The requirement for this is 1.5 hours of education, and this is required of all nurses in Kentucky and is included within our curriculum. As you see here, the most common cause of child abuse that results in fatality and long-term disability is the pediatric abusive head trauma. It's defined as blunt trauma to the head or violent shaking, and is the leading cause of head injury among infants and young children. Child abuse and neglect continue to be a significant problem in the United States, and particularly in Kentucky. In 2009, approximately 1,770 children died from neglect and abuse, and more than 40% of these deaths occurred in children younger than 1 year of age. This information was taken from the Child Welfare Information Gateway of 2011. So as we look at a definition of what is pediatric abusive head trauma, it's injury that occurs from vigorously shaking an infant or child by the shoulders, arms, or legs, or deliberate direct blows to the head, or when the child is deliberately dropped, causing brain damage, blindness, paralysis, speech, and language disorders, and of course the potential for death can result. Some more statistics and scope of the problem and cost. As you can see from 2008, these statistics were taken, that there were 58.7 per thousand children of 3 years of age and younger that reportedly had pediatric abusive head trauma. Of this total, infants younger than 1 year of age comprised 21.7 per 1,000 births. So then the medical costs that are associated with this long-term care range from $300,000 to over $1 million. And these numbers, of course, are from the CDC. So as I said earlier, the exact definition of pediatric abusive head trauma, the injury in a variety of outcomes from vigorously shaking an infant or child, and that can be by the shoulders, the arms, or the legs, or can be the result of deliberate direct blows. And this can occur in a matter of seconds, and is from as few as 3 violent shakes, and generally the child is under 2 years of age. The purpose of this presentation is to provide you with current information, evidence-based practice, and the implementation that could be provided as interventions to families and children to help with the prevention and diagnosis and treatment of PAHT. So it is hoped that you could recognize predisposing factors, that you are aware of the risk that are related to this incidents, and you will develop skills to plan and implement preventive education within your community setting, to provide you with a working knowledge base on PAHT, and then hopefully there would be a reduced incidence of this type of child abuse. This can also be looked under domestic violence or child abuse, but is referenced to specifically now as PAHT. You should be able to describe the significance of the problem, the long-term consequences, to understand the terminology, the causes for it, the common associated injuries, and then, of course, that you can prevent the situation. The CDC in 2011 defined child maltreatment as any active series of acts of commission or omission by a parent or other caregiver that results in harm. Over time, child maltreatment has also led to increased death in adults because of subsequent complications. It is classified as a significant public health issue, and so looking at the treatment for the child and also the parent or caregiver. It is a reportable incident, and it may encompass multiple situations. 1,000 to 1,500 infants per year have been diagnosed with PAHT, and it's the result for 2,000 fatalities per year. And for some reason, it is more common in male victims. 60% of all cases are males, and 1/3 of the victims die from injuries. 1/3 will suffer life-changing injuries, and 1/3 will continue to have minor injuries as the result of the trauma that is sustained. Cause and risk factors. One of the primary ones that we see for being a trigger for the parent or caregiver is crying without being able to be calmed or quieted. This crying for longer than a normal 20 to 30 minute period. The parent or caregiver becomes frustrated and angry at the inability for the baby to stop the crying. They lose control in the incident, and they end up shaking the baby or striking the baby. There does seem to be a risk factor of the baby being premature or a baby with a disability. They seem to have a greater risk of suffering from PAHT. And as I said before, being a male, perhaps this is the expectation of the male infant to cry less, a misunderstanding, a lack of knowledge in regarding infants in general, the thought that the male should cry less, and the other is that the male infant reminds the single parent or mother of the bad relationship with the father. So she relives this bad situation within her own personal life, and then is unable to control her emotions in regarding to the baby who isn't stopping a crying episode. Of course, also the baby being small enough to be picked up and shaken or slammed is another factor. And then, of course, they're totally dependent on caregivers, and the parent or caregiver is socially isolated. And this could be emotionally, physically, and financially as well. We also see an increased incidence or a risk factor of multiple births. Of course, you're just multiplying the situation or events that may occur normally with infants, and then if there's multiple births, that's just increasing those risks. Characteristically, we see a pattern, and so you need to be aware of the pattern. There's not just one thing that would say, yes, they have this characteristic and they will ultimately be involved with a pediatric abusive head trauma incident. But what we do see is a pattern or a clustering of characteristics or risk factors, and so that you as a healthcare provider, whether you're working in a nursery, a NICU, an OB unit, an emergency room or pediatrics or a clinic, our school nurse, these things that you would be or should be aware of. One is that the caregiver is young, so therefore they may not have the knowledge level, the experience, the ability to control their emotions. They are probably a teen or perhaps in early adulthood. Often it is a single parent, and again substantiating the fact that they do not have a safety net, they do not have someone else in the home that can assist them when the baby's crying. Lack of education. When we see this lack of education, there is typically a lack of understanding of what is normal growth and development, what are the normal expectations of an infant, what can an infant do, and how can an infant be quieted or comforted. So when we look at the education piece, it may be that they did not graduate, they do not have a high school diploma, but encompassed with that is that lack of knowledge and understanding of infant growth and development. Low socioeconomic status. Again, they may not have the resources to assist them with, daycare, timeout, any of that. So they are with this baby 24/7 and have no release from the situation or no break. They probably have a high stress level. Again, they've not learned coping skills to deal with crisis or stress interventions. They may have made poor decisions, of course, about even sexual activity and the pregnancy, so we can see that their stress level increases. They may have a large number of dependent children. Maybe this is the last of several children that are born. It's a premature, for example. We also may discover within their own health history that this caregiver was abused in some way as a child or neglected. Isolation, again, is a big piece that we see, and this feeds into that low socioeconomic status. They do not have a safety net, they don't have resources, they are in a very confined space with this baby constantly. There may be a history of substance abuse as well as, again, a high stress level and poor decision making. There may be a mental health issue also within their history, and sometimes we see that now they have a new adult partner that is in the home that is not the father of the baby, but yet another partner that is there. And it is sometimes that partner that leads to the abusive situation. Non-biological transient caregivers in the home. It may not be just that there's a new adult partner, but there may be several people that are transient within this situation. Again, the low socioeconomic status, the environment may be being shared by multiple people, and again leads to a stressful situation. The caregiver often has feelings of inadequacy, low self-esteem, decreased ability to make decisions, to deal with stressful situations, and again doesn't have the educational background to make those type of decisions of critical thinking. Often we see signs of exhaustion in the caregiver. Again, that, it leads from, not having any resources, not having any time outs for themselves, constantly with this baby who is crying and they can't console them. Limited anger management skills, again, that they aren't able to control their own anger. They take it out on others, and of course within this situation it would be that they're taking it out on the infant. All in all, then, this leads to what we might refer to as an unstable family, and there may be behaviors of this individual that we see are very rigid in their attitudes and very impulsive in their responses to situations of stress. They often have a history of poor parent-child relationship in their own life, and again, become very irritated when the child or infant is crying. When looking at their perception of themselves, they often have that very low self-esteem or negative view of themselves as a parent or a caregiver. The pregnancy may have been unwanted. The other aspect that we see is they wanted the baby. They gave the baby up for adoption initially on the OB unit, but then decided to keep the baby. Then we see that there is some type of abandonment by the baby's father, and so again, a very complex family situation. An unwanted gender of the baby, when on postpartum, when you're talking to the mom and there's a great deal of dissatisfaction with the gender that of the baby that she has, or even a dislike or repulsiveness to normal things about the baby, such as, their umbilical cord and how it looks, or a bowel movement, or changing a diaper. Those also should be red flags to you to further assess and determine the mother's ability to care for this baby within the context of what's normal. We also can see incidents occurring when there's a crisis situation, death, divorce, and often financial situations that now become just overwhelming to the caregiver. Some of the triggers, then, when we look at all of those characteristics or risk factors, it's not saying that, an unwanted pregnancy is always going to end up with, an incident of pediatric abusive head trauma, but it should trigger us to further assess the stability in the situation and help to provide interventions and a safety net for this family unit. The crying is, a really big trigger, and it's that persistent crying, and it's frustrating to the caregiver, and the baby does not console, so it becomes kind of spiraling situation. The baby doesn't stop crying. The caregiver reacts in a very irritating way, not in a soothing way to the baby, which then makes the crying intensify. They don't understand the different types of cry and how the baby is trying to communicate what their needs are. So we'll see that them shaking the baby to try to stop the crying, and then that can lead to apnea. Long-lasting episodes of apnea may result in hypoxia, causing cerebral edema and increased intracranial pressure, but that crying and not being able to console. Another period of stress for the caregiver may be when toilet training is occurring, and the caregiver inflicts punishment physically as a result of soiling. So again, they lack an understanding of what's normal growth and development, or what's to be anticipated in the toilet training. So we can see triggers of this nature being of an issue between that 12 and 48-month-old. So again, that lack of knowledge and understanding of the baby. So if you're seeing a baby brought into the emergency room, in a clinic, wherever that might be, the initial signs may not be clearly obvious, and that is why you need to be aware of specific triggers and situations that may exist that would be risk factors for PAHT. The situation may range in severity and specificity, and the infant may appear normal. There may not be initially any signs of increased intracranial pressure, but what we might see are some more subtle differences of poor feeding, sucking, swallowing, and perhaps even a decrease in their normal progression of growth and development. Any bruising on a child less than 1 year of age should be assessed further and more information obtained regarding the nature of the bruising. Multiple bruising on multiple areas of the body that are not normally explained, and the caregiver may give an explanation that doesn't fit the situation. Bruising on the forearms, from tightly holding and shaking. Bruising on the abdomen, ears, and neck in children less than 4 years of age. If you see an infant coming in with vomiting and there's no history of any viral infection, they don't have diarrhea, it's just this vomiting, then also look at their behavior. Are there signs of lethargy, and what is their sleep pattern? What is their muscle tone? What is their behavior? Do they track? How do they respond to someone in the environment? Decrease in verbalization or smiling. They should have that social smile at 2 to 3 months, and so if there's not this engagement or there's a decrease in verbalization, they should be saying 2 to 3 words at 12 months of age. The cry, is it a cry that indicates increased intracranial pressure, that high-pitched, grating, irritating type of cry, which, if they're having this, then again, that's going to trigger yet more inability in the parent to deal with this very irritating type of cry. Any other behavioral changes that you see in the baby or the young child, perhaps seizures that were not preceded by a febrile illness, no history. We need to look at what are the causes of seizures. Is there any rigidity? Is there arching of the back when held? Are there changes in their pupil sizes? When you look at that as a neurological indicator. Vision loss, they're not tracking objects. Inability to raise their head, again, may be indicative of that increased pressure and the size of the head itself. Of course, when there's more impending physiological outcomes would be difficulty breathing, a slow pulse, and of course that bulging fontanelle could also be an incident or a sign that you might see. So when we think about what's causing the cerebral edema of increased intracranial pressure and PAHT, it's called the classical triad. There's subdural hemorrhage, cerebral edema, and retinal hemorrhages. And it can be classified as primary from a direct injury and sharing and movement of that brain tissue, and actually even cellular death to brain tissue, and secondary as results of direct injuries and systemic events. So we can see both primary and secondary classifications of the type of cerebral edema. Long-term consequences, we can see respiratory center being affected long-term. They may have periods of apnea, inability to breathe and swallow, and of course that can affect them nutritionally. Developmentally, they're typically delayed in not sitting up, unsupported at 8 months. They're not walking, with that outer limit of 15 months. Their muscles may appear weak, or there may even be paralysis. They may have some symptoms that are similar to CP, such as spasticity, speech problems. Over repeated incidents, there could be severe mental retardation, and as I said, this may appear like, cerebral palsy, but it's due to PAHT. Emotional difficulties, seizures, hearing loss, partial or total blindness, learning disabilities, and then of course it can even result in death. So it's important, if you see one of these symptoms, one of these psychosocial factors, that you obtain a complete history and know about the home environment. This is not caused by disease, it's not caused by immunizations, not caused by CPR or SIDS. It's not related to a shortfall of less than 4 feet. It's going to be more of a shaking situation. So if they said they fell and it's like a 4-foot span of what they fell, that's not what is causing this. So very thorough in your history, knowing the risk factors and triggers, assessing the timing of events, noting the type of responses that you get from the caregiver. They may change their history. They're not a good historian of the events, or their responses may be vague. Often we do see that inconsistency and that their story changes over time. Remember that you want to do a thorough review of their history and notation of reports. They may go from one clinic to another, to one emergency room to another, and with our emerging electronic medical health record, hopefully that information is more likely to be accessible, that we can compare those events. Looking at your well-check appointment notes, they missed an appointment, and what are the changes that we see in the behavior of the baby. You always want to know who cares for the child, who lives in the home, any changes in family members, have there been new people within the home setting. Have they waited